Andre Theron from South Africa Republic. We told yesterday about the time and Kiev in Cape Town, and we understand that Cape Town are very far from Kiev, but we have another time. And I think Andre, it's a very good speaker for our first day, and our big friend Andre. Nice to see you, and go on. And thank you for your participation in our meeting.
Oh, it's a big pleasure. Thank you very much. Thank you for asking me. I'm just going to share here, and then we can start. Can you see the screen? Everything good? Good.
Yes, yes,
All
yes.
right, good morning.
Yes.
I'm Andre Theron. I'm here in sunny South Africa. Unlike your cold weather, we have very hot weather at the moment. It's already 28 degrees Celsius, and the temperature is climbing. Good. So I'm going to talk about regional anesthesia in high-risk patients and critically ill patients. Right. There we go. So firstly, when you think, I'm just going to be a little introduction, the advantages of using regional anesthesia in these patients, and then some disadvantages, but how to overcome them. And then if we have time, there are some case studies that I can just present to you. Firstly, when you think of high-risk patients, it can be trauma patients, very, injured patients, multi-trauma, polytrauma patients, or it can be patients with multiple comorbidities. So these patients also need attention and care, and they are at very high risk due to their comorbidities. Now, this picture has become all too familiar in the recent setting with the COVID virus. So when you think about regional anesthesia, we can circumvent some of these risks. So firstly, it avoids complications due to general anesthesia. There is no airway manipulation necessary if you do regional anesthesia. Aerosolization of COVID is not a problem. You do not get bronchospasm. Your patient does not necessarily aspirate. There's no prolonged sedation or muscle weakness, especially in patients who have muscular dystrophies or other muscular diseases. Then your patients have less postoperative nausea and vomiting, mostly because you use less opioids. And this is also good for the hemodynamics of your patients. And in high-risk patients, where you have patients with severe respiratory disorders, obstructive sleep apneas, and patients with chronic obstructive pulmonary disease, you do not want to use too many opioids to cover their pain. Then regional anesthesia gives you superior pain relief. You can use it as a sole technique, and it has also been proven to decrease the risk of chronic pain. Now, it also gives your patient improved respiratory function. This was part of the master trial that was done in 2002 already, when they looked at epidurals and spinal anesthesia versus general anesthesia, and then the respiratory complications or respiratory positiveness from there. Then we also see decrease in arrhythmias and less risk in acute coronary syndromes. Then further, when we look at further advantages, the analgesia continues way into the post-operative period. So if you do a single shot block, then we will have regional anesthesia for anything from 8 to 16 hours, depending on the drugs that you use. But with new catheter techniques or infusion techniques, we can make the blocks last for several days. I had a patient in Belgium who had a brachial plexus injury with a traumatic amputation. Obviously, this was very painful. We put in an interscalene catheter for him, which we kept in for 45 days without any complications or problems. So it can be done. Then patients are less sedated post-operatively. So this decreases confusion, especially in your elderly patients. We have lots of elderly patients here where I live because it's a beautiful place close to the ocean. So everybody comes to retire here. So we have lots of elderly patients with comorbidities, and confusion is a problem. We need to send them home as quickly as possible. And regional anesthesia has shown in multiple studies and meta-analyses that it causes less sedation and confusion, specifically post-operatively. Then your patients have a faster return to street fitness, which means because you're doing a less invasive procedure to get to the same aim, you can still do the operation, but with less invasive anesthetics, means that your patient will have a decreased length of stay due to anesthesia complications, which means cost saving eventually. And in these days where we are, hospital space is at a premium, we need to get patients home as quickly as possible. Then regional anesthesia can be done in remote locations. It is cheap and relatively safe. You do not need elaborate equipment to do even high-risk patients. Your equipment can fit into a small carrier bag. But in high-risk patients, there's always disadvantages of using regional anesthesia. And these can be that it could be redundant because you have a polytrauma patient who is already intubated, ventilated, sedated. If you do these regional anesthesia procedures, it might not be necessary. He's already on high doses of opioids. So then also it is not clinically proven to give a better outcome, but there is strong evidence that supports it. So we're still waiting for meta-analyses and bigger analyses, but the outcomes do not necessarily improve, but complications do. You still might need opioids to cover the full range of pain. And remember, with your regional anesthesia, unless you keep in a catheter that you keep in for a few days, your patient may still require opiates. Then, if your patient has polytrauma or there's multiple sites of operation, it might be difficult to block everything with the available, safe dosage of regional anesthesia. Then it might alter signs of compartment syndromes. Now, I've only put that in because they quote this in every article. I have looked into the research and there is very good, robust research that shows that a compartment syndrome does not get hidden by regional anesthesia. It is actually a good thing because breakthrough pain in a patient with a good working block is a sign of compartment syndrome. So your patient will still have pain because it is an ischemic pain. Then monitoring the blockade in an uncooperative patient, the polytraumas or patients who are already intubated is quite difficult or near impossible. Then stopping DVT prophylaxis. Now, this is only a problem in patients where you want to do central kind of blocks. If you want to do epidurals, paravertebrals, spinals, things like that, that is a problem. But in all other blocks, unless it is a confined space where you're putting in the block or an uncompressible site, it usually is not a problem to do it on full anticoagulation. Then you do need some technical expertise to do regional anesthesia well in these patients. But on the other side of this, you also need some technical expertise in general anesthesia to manage a polytrauma or high-risk patient. Then need for patient positioning. It is not always possible to position your patient in the optimal position to do regional anesthesia, but we have such a wealth of skills now and so many routes that we can take to do the same kind of block, whether in plane, out of plane, anterior lateral. We can do the blocks from any which side, especially now with ultrasound use. So positioning is not a big problem anymore. Then anatomical landmarks might be difficult. Yes, it might. But then again, if you know the anatomy and you know your sono anatomy, this shouldn't be a problem. Now, I just want to touch on some of these disadvantages or some of the problems why people say, no, we shouldn't use regional, just do a general anesthesia for these patients. And then I want to give you some possible solutions so that you can use regional anesthesia because it is better for a patient. I might be biased, but I have had very good success. So time delay, both performing in the block and waiting for the block to work, but again, in a critically ill patient, doing a proper anesthesia also takes time. Now, what can we do to mitigate this? Firstly, you have to have time neutral areas and block rooms. So preparatory rooms where you can do the block and then take them into theater so that you do not waste theater time. Then use an ultrasound. When you're doing blocks, the use of ultrasound doesn't necessarily make you do a better block, but it makes you do the same block much quicker. In a study that they did on interscalenes, the success rate was 100% whether you used sonar or not, but with ultrasound, it took 4 minutes to do a single shot interscalene versus 10 minutes to do it with neurostimulation techniques. Other studies have proven the same. Then using the correct regional anesthesia or local anesthetics, choosing your drugs correctly to help you speed up the time. And then slow epidural titration in patients, for instance, with aortic, critical aortic stenosis, also takes some time. So whether you do a general anesthesia for these patients or a slow titrated epidural, both will take time. One will be much safer than the other. Then there is some discomfort associated with these blocks for positioning in patients, especially elderly patients with comorbidities. They might be very anxious about having blocks in an awake situation. What can we do to solve this problem? Well, some skin infiltration with lignocaine, lidocaine, also and the emulsion of lidocaine, prilocaine that can be put on beforehand if your patient has a fear of needles. Can use small doses of midazolam and ketamine. This is safe in most all patients. You know, ketamine in small doses is even safe in the contraindicated coronary patients. We have seen no problems with that here. Then also you can go a bit larger, remifentanil, propofol infusions. These are all short-acting drugs, so you can stop them quickly if need be. Then something else that I have used to great success, using headphones and music for these patients, even maybe, you know, having them with their own cell phones. If I'm not talking about the polytrauma patients, I'm talking about patients with severe comorbidities, elderly patients with chronic obstructive pulmonary disease, with heart disease, etc. If you distract them a little bit, play some music, or you put some headphones on, they are very comfortable. So it feels a little bit like fighting a bull when you try to come near some of these patients. Then surgeons. I don't know if this is an adequate representation. Our surgeons look like this mostly. Some surgeons are very irritated and distracted because of awake patients, especially high-risk patients. There's lots of stress in the room. So the surgeon doesn't necessarily want the patient to be awake because the patient will lie still or the patient will move and this is a critical patient. Well, what can we do? We can do some light sedation, either to the patient or to the surgeon. That you can choose which one, but be careful of over-sedation, because an over-sedated patient becomes confused and sometimes they start fighting. So just make sure that you can slowly titrate up your sedation. And then, as I said, patient distraction, keeping them busy will keep them from moving about. Your surgeons will, however, have to learn some different surgical techniques to operate in an awake patient. If you do abdominal surgery in an awake patient, which I've done before, traction becomes a big problem. So you have to tell your surgeon beforehand that they can't just rummage about like a few raccoons in the abdomen. They have to actually use good tissue techniques, and you know, anything that they do, they have to do slower and just not clamp quickly or pull quickly on anything. Then also, Wallant, wide awake local anesthesia, no tourniquet, is becoming ever more popular surgery-wise. So your surgeons will have to learn these techniques because they are getting more prominent. Using no tourniquet is different, especially in orthopedic surgery. I don't know how your orthopods are, but mine start crying like little babies if they see blood. If the tourniquet is not on, you know, 400 millimeters of mercury, why is it bleeding? So that's sometimes a problem. Then block failure. This is a big problem, especially in these critically ill patients. There can be up to a 10% failure rate, which means conversion to general anesthesia, and then your patient is exposed to the risk of both the general anesthesia and the regional anesthesia. So block failure is a problem. But how can we mitigate this? How can we decrease the risk of block failure in these high-risk patients? Well, firstly, I'd just like to quote Denny. He said, regional anesthesia always works, provided you put the right dose of the right drug in the right place. So I'm fully with this. If you do the right block in the right place, your block will not fail. Then, know the surgery and the incisions. In one of my later talks, I'll talk about the surgical incision sites. And knowing where the incision sites are means that you can plan your regional anesthesia better, so that you know exactly what to block, so that you do not get a block failure. And a block failure is basically where you need to do something more after incision. If before incision you find out, oh, look, the block isn't full, then you can do a rescue block. So just know the landmarks, know the sonar anatomy. This is important. You cannot do regional anesthesia without knowing anatomy. You can try, but you will be a really bad regionalist. So landmarks, both anatomical landmarks, the anatomical movement of your structures, as well as the sonar anatomy, is very important. Okay, use of ultrasound important, and know which rescue blocks to use, so that if your block doesn't work, what are the other options to do the same thing? Because we have more than one option for most blocks. And then you use a block room so that you can see that the block works and test it beforehand. Then I don't know if we have still some time to do some case studies. I had a patient, 58-year-old female, presenting with a T2N1M0 invasive ductal carcinoma of her left breast. She was for a mastectomy with axillary dissection. Patient is known hypertensive, well controlled, but she reports that during 2 previous surgeries, one for a broken ankle and one for a tubal ligation, that she had sudden asystole in both surgeries, and both were done under general anesthesia. The last one, she was admitted for 2 weeks after her asystole in ICU. No anesthetic factors could be identified. There was nothing leading up to it. There was different drugs used, different times, different anesthetists. She had a full cardiology workup and genetic testing, and they could not find a reason for this sudden asystole. But now your patient needs a mastectomy, but refuses general anesthesia because of the 2 previous asystoles. So I was approached to do the case, and we did so with regional anesthesia alone, doing PICS blocks, serratus plane blocks, and blocking the anterior the anterior ramus as well. And this is our patient with having her mastectomy and axillary clearance. You can see that she just has an oxygen mask on. She's had 1 milligram of dormicum just to keep her restful. Surgeons were very, very happy. She was very happy. The result was good. Then a 43-year-old male presenting with local recurrence of sarcoma for excision and skin flap by the plastic surgeons. He's known diabetic, hypertensive, poorly controlled, obstructive sleep apnea, on CPAP at home. He obstructs, very easily. He's super morbidly obese and mentally handicapped, getting nursing at home. Here is our patient. So general anesthesia in this patient, he would need to be proned because the surgeon needs the good traction on there. If he lies just on his side, he wouldn't be able to do the flap with the right tension. So he would have needed to be prone. So you can imagine that this patient is a high risk anesthesia. What we did for him was an ESP block with the option of doing some infiltrations locally. We did it at a T3 level, left here, and it worked like a charm. He received also 1 milligram of dormicum and some 5 milligrams of ketamine. He was completely happy. The surgeons could do their work. There was no area that was not covered, and he did the operation with the patient in a seated position. Okay, and lastly, 81-year-old male presenting with a proximal humerus fracture with a completely destroyed shoulder after a fall from home for a shoulder replacement. The patient is a COPD patient, gold class 4, on 21 hours of home oxygen. He's known hypertensive with cor pulmonale, and with his previous TURP, so prostate, he required 2 weeks of ventilation in ICU because he was so difficult to get off the ventilator. We used regional anesthesia for him, did a dry block, what we call interscalene. So I used saline to place the catheter in the right position, and then slowly started giving small boluses of lignocaine until we had the desired effect. And the patient did not have any respiratory complications, went through the surgery completely awake, just with nasal prong oxygen. It went very, very well. So just want to quote Jose Aguirre. He's a well-known researcher from Switzerland. General anesthesia is fast and known by all anesthesiologists. However, concerning post-operative pain, complications needing readmissions and costs, regional anesthesia offers major advantages. Moreover, the aging population with a higher level of morbidity will ask for anesthesia regimens with low impact on cardiac and respiratory function, and this will translate into reduced direct and indirect costs. Good. So now that you all know that regional anesthesia is awesome, you agree with me, sign on the dotted line. I hope I stayed within my time, and I'll see you a little bit later after some coffee.